So our next speaker is Dr. Farnan, the Assistant Dean for Curricular Development and Evaluation at the University of Chicago Pritzker School of Medicine, talking on entrustment, supervision, and the electronic health record.
Do I point this way? Oh, I think I win for shortest, so I'm glad Stan wasn't up here right before me. So I want to thank Mark and Joan and everyone for inviting me here today to talk about our experience at the University of Chicago, and much more focused on the GME side of things, but really thinking about how do you operationalize and do some of the things that we've talked about this morning, integrate workplace-based assessment into the flow of a faculty member's workday, and also use that to provide supervision. Let's see. All right, so, the question of the EHR has always sort of been this sort of looming in the background, is going nowhere, and we know this. But, we have really very little data on what are faculty doing with the EHR offsite, at home, when they're not on the wards with residents. We know from prior work that residents clearly are stalking the EHR at home, and very much hoping the ACGME folks in the crowd are not counting these hours, that they're checking labs and oftentimes even calling and making changes to the clinical plan of care based on things that they're seeing in the EHR from home. And so one of the big questions that we have, and what was really unknown in the literature, is whether or not faculty are doing similar things and using that data to make supervisory actions or to result in supervisory actions for their house staff. And so there has been some qualitative work and a little bit of work done in the procedural areas regarding faculty's experience with CPOE and EMR/EHR. And while it has its positive aspects, it allows for faculty members to review things in real time, see data as it's evolving, there are definitely some issues specifically around sort of taking autonomy away from junior learners. So faculty who really have never let go of being the intern and are going in and buffing K and ordering CTs. And that is something that feedback from house staff has been negative, in that it's sort of taking away their primary role. And using things like templated procedural-based notes, obviously increasing the yield on procedures and billing and RVUs and all that good stuff. So we wanted to do two things. First, we wanted to look at what was our faculty members' experience on the inpatient general medicine service using the EHR in sort of a supervisory framework. Were they using it? How are they using it? What were the results of that? And then the secondary piece that I'll talk about is how do we integrate that into more of a workplace-based assessment around handoffs, not the UME to GME handoff, but the more traditional inter-hospital shift-based handoff. So the first study that we did really looked at whether or not faculty were using the EHR to make supervisory decisions or actions while they were on the inpatient general medicine service. We have a relatively traditional overnight call structure with one faculty member as the ward attending on for a 2-week block, with a resident and 2 interns. And so we did a study with a fellow of ours over the course of a year and a half, and we had 45 faculty members. The numbers break down by specialty, as you see above. We did have some chief residents who are appointed as clinical associates who attend on the wards as well that were not included in this sample. But we really wanted to look at how were they using the EHR from home, what were they doing with it when they weren't on the wards, when they were physically in a disparate location from their house staff, how are they using the EHR, and were they using it for supervisory actions? This is our fancy, lovely, I don't know where the pointer is, new hospital pavilion called the Center for Care and Discovery, which is conveniently located approximately 3.8 miles away from most faculty offices. And so people had been using, yes, the underground tunnel system rivals your subway to get patients from our emergency room to our ICU. And so people are using the EMR a lot remotely and physically separated from their house staff. So it's a mixed method study that involved both an in-person interview with the faculty member the day or two after they completed service, and a survey as well. And one of the things that we wanted to focus on really was looking at these sort of not necessarily just a documentation review, but really what were they doing with that clinical information, and was it triggering a supervisory action? So when the faculty member was going into Epic, first of all, when were they doing it? What time of day? How long were they spending on Epic, which is our EMR? And then what was the actions that were triggered based on the things that they saw in the EMR? Did they take any supervisory actions as a result of what they saw? And so I'll report some of the quantitative data first, and then the qualitative data, which is more my speed. Oh, I'm sorry? Oh, point to the back. I'm sorry. Okay, there we go. I am so short that I can't even see the screen that's supposed to be down here for me to prompt. So I'm going to do this and go anti-podium here for a second. So the first graph that you'll see here is really looking at the clinical information review. And so we asked faculty, or our fellow asked faculty, how frequently were they performing these actions? So how frequently were they doing at least once a week, or maybe frequently 3 times a week, reviewing all the patient's medications or confirming clinical information that they had received from their team, and then looking at other clinical information that they thought didn't get quite relayed by the team adequately. So you can see, people are using Epic to do clinical information review. At least one time they're looking at the medication list for a patient. At least one time they're going to go in and say, I'm going to confirm that what the resident told me the CBC is correct. So faculty are going in and they're using that information for review. But the more important data, I think, is that faculty were using the data they review on Epic in order to trigger supervisory actions. More than 50% of attendings saying that they saw something on Epic that was so disparate from what they heard on rounds that they personally actually paged the cross-cover intern to implement a new plan of care for that patient. So again, triggering a supervisory action to the house staff and then resulting in feedback to the primary team. This, not something, as someone who trained at U of C, was not sort of the culture of the way attendings and cross-cover usually happened, right? Your attending wasn't at home calling the lab to get the PTT result and telling you what you should do with the heparin drip. And so these were a lot of the changes that were happening, and we had more qualitative data around the kinds of things attendings were calling for. And these were things like the patient didn't get fluids and they're going for a CT and their creatinine was abnormal and someone missed that, or they weren't NPO for a procedure. So really getting into the weeds, as it were, to say these are the supervisory actions that were triggered by what I saw on the EMR myself. The qualitative data is I think, my sort of more personal love, and really reveals a lot of how the EMR has sort of not only changed rounds, but also the way we approach supervision. So I love the second quote, and I think it really captures things really quite eloquently. Rounds no longer are a time when we are going to exchange clinical information. Before I get to the hospital, I know every single thing that they're going to tell me. I know the vitals, I know the labs. I don't need to spend 3.5 hours walking around hearing about that again, right? Should we be repurposing that time and thinking about how do we use that for assessment in real time, right? Because like this attending says, back in the day, you watch the news at 10 o'clock, that's when you got the news. Now I get it on my phone every 10 seconds, and I go to Twitter as my news feed, as opposed to waiting to hear it from Dan Rather overnight. Supervision is a completely different scenario, right? So I love that I'm going to be Ronald Reagan. I'm going to trust but verify, because now we have the ability to go in and figure out, are they doing what they said they were going to do? And how did they think about this issue? Because again, when the H&P stayed in the chart at the hospital and I went home, I didn't get to think about how did they think about that differential for that patient, or how did they approach that plan? That was left at the hospital, but now, and especially from our follow-up data, we know faculty are reading these notes at 10, 11, midnight, 2 in the morning, and this is when all the documentation is happening, and this is when people are reading these notes, but they can also use that to assess their residents' clinical skills and clinical diagnostic reasoning. So we had a high report of the EMR being used for electronic supervision, so confirming things that they were told and really having attending-driven changes. Looking at the demographics of our sample, there was no difference if you were a year in practice or 10 years in practice. If this was the first time you worked with a resident, or if this was a PGY3 who you knew was going off into some subspecialty-based training. This really was across the board. There was no difference between attendings or trainees. But informal and non-standardized. And I think today, if I took away from the morning, one of the big messages is that faculty development is hugely important. And if we think about a way to use the EHR, especially when we think about meaningful use, what could be more meaningful use than finding a way to make it educational and supervisory? And then really, there was really no performance assessment. We did have a lot of attendings talk about how they would read the H&P, they would look at the assessment and plan specifically after all of the 78 years of mammograms and chest x-rays that were auto-filled into the H&P to get to the very bottom and read that assessment and plan and really get a sense of, the resident sometimes can arrive at the right answer for all the wrong reasons. And you can read that and say, wow, they really missed the boat. And they told me that they knew the patient had X, and they got to X, but they really got there the wrong way. And so I know where I should go with this, but we haven't found a way to really accurately capture that performance assessment? And how can we think about using the EHR to teach, right? The rounds of the past are the past. And I've mentioned to Eric and others today that when we kicked off our new curriculum several years ago, Jordy Cohen came and gave a speech for our medical education day, and he said, curriculum reform sometimes is like putting wings on an Edsel and calling it an airplane. And I think that's where we are with rounds right now. We continue to do the same thing over and over again. And we really have an entirely different system and different needs of our learners. And can we think about using the EHR as a teaching tool? Can we think about capturing sort of what we are thinking about, capturing our own clinical reasoning and relaying that to the residents? In our follow-up study, we looked at when the attendings were signing their notes, what time of day, and whether or not they were actually putting something in the attestation, right? For those of you who have Epic, dot, attest, F2, 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 none is usually the way people sign their notes. And there's a lot of none in that attendings comments. But when you put something other than none, the resident goes back and rereads the note. Significantly more likely to read that note than if you put none. And so, we've talked through that with the residents, and they love to go back in and read and see, how did you think about that problem? So I think it's a missed opportunity. And since we spent all day talking about handoffs, I would be remiss if I didn't talk about how we've used the EHR and direct observation to really assess handoffs in a real-time way. So I don't have to convince all of you that handoffs are an issue, that we have a lot of shift change, both inter and intra-hospital, but I'm talking specifically about shift change at the end of a post-call period. We know that this is important, right? ACGME, CLEAR, AAMC, everyone's on the same page that handoffs are important, they are critical, it's an observable skill, and guess what, has an EHR component that we can leverage. And so while a lot of work is focused on that verbal handoff and how do we give information to one another and back channeling and read back and all that great stuff, there are other components, specifically the written component of the sign out, that oftentimes is either some native or homegrown piece, but oftentimes is integrated into the EMR or the EHR. And we have our own special U of C brand of the sign out that's in Epic that we've worked on over the years, but ours is integrated within our EHR. Obviously, that also involves that transfer of professional responsibility, which was mentioned today earlier in the speech by Eric Hombo. So a lot of it, like I said, focuses on communication, but many people neglect that written document, that sort of peripheral brain that interns keep in their pocket so they know what their to-do list is and what they have to check off and when. So we decided to use the literature and expert opinion to create a chart audit to look at written sign out. Now, we already had a system in place where we have on our post-call day a teaching resident who's a PGY 2 or 3 that's referred to as a day float resident. That person does a direct observation of the intern to intern sign out at the end of the night when they leave their shift at 7 p.m., does that through MedHub, the MedHub app that we saw earlier, and provides the intern with some feedback on their verbal communication. But we've been using core faculty assigned to each of the clinical competency committees to be assigned to a pod of interns where they do written sign out evaluation. So this is the updated audit tool that we created. You can probably see it better on the side, but it basically goes through some of the critical issues of the written sign out and whether or not they are updated. Is the updated identifying information, like the location of the patient and their code status? Has the patient's problem list been listed? Has the one-liner in the HPI? Is there addressing their code status? Are all of the different aspects of our specific sign-out document updated every day? So each intern had audits of their sign-out done in the first quarter of the year. And if they didn't achieve adequate scoring, we went back and redid audits throughout the year until they all were able to achieve competence. And so you can see here we have 45 PGY1s at the University of Chicago. That includes preliminary positions. And in the July through October, we had only about 45% satisfactory. So this is on the, if you can see it in the back, the scores are poor, fair, and good. So if you were poor or fair, you had a repeat of your audit. If you were good, you had one additional audit done, and then you were good for the year. And so you can see here we had 43% that were satisfactory in the initial phase of the audit, then November through February, and 84% satisfactory. Thankfully, by March and June, magically, everybody became satisfactory. But there was 136 total audits, and it's actually really gave us a window into what was going on the written sign-out component. Number one, the fact that most of the time the PGY2s were taking this responsibility from the interns and were doing the sign-outs themselves and not allowing the interns to do the sign-out because of efficiency pressures. And so we had to have a sort of intervention with the PGY2s and 3s to say, this is an important part of their learning. They need to be able to synthesize all of this together. You need to let them do their sign-outs. So then we went through, used Epic to be able to know who was updating each of the fields. And then once that was, education sort of happened with the PGY2s, we saw a real improvement across the interns. And they had an average of about 3.1 audits per intern, but really took that information and the sign-out feedback that they received to then improve their performance. The core faculty all received training on how to use the audit tool beforehand and also on the handoff processes that we use. All of the interns to U of C, when they come in, do an orientation where they do floor station OSCE, one of them being a handoff OSCE, which looks at their verbal communication skills, and we do track those over time, so we didn't feel the need to kind of put them back through the standardized environment. So where do we go from here at U of C? Well, we're doing a combination of both real-time and independent review, like I said. So we're doing real-time sign-out audits now continuously with both the interns and the fourth-year sub-interns, as well as doing those observations with the day float. And now with the on-call attendings for the general medicine services, seeing the interns sign out to one another. So we have both resident and faculty level feedback for the interns, and really integrating that into a part of the attendings workflow for the day, so that it is an expectation when they come in that at the end of their shift, they're going to be doing some sort of direct observation of the handoffs. In terms of using the EHR for clinical supervision, really been about transparency and letting the residents know that this is what we're doing. We're looking at not only their documentation, but their orders, and we'll be providing feedback for that. We haven't formalized that process, but I do think that the big thing that we've really gotten pushback on is that it's been a huge change in expectations and culture. No longer can you sort of come in at 8:30 and round for 3 hours and go through morning report and not really have time to spend with the residents, not only providing feedback on their skills, but also sort of using the data that you have from the EMR to kind of give them feedback on their performance. So I'll be happy to take questions at the very end, but thank you for letting me share our experience.